Hello everybody. Today's topic is plasmapheresis. So we have this 19-year-old male patient, no comorbidities. He came with alleged history of rat poison. Consumed 1 spoon of rat poison, which was yellow phosphorus. Initially went to local hospital, received symptomatic treatment, and then came here for the further management. So when he came, his MED score was 32, and he received 3 cycles of plasmapheresis. So we have this another patient who is a 34-year-old female patient, known case of diabetes mellitus myasthenia gravis on treatment. She presented to OPD with history of drooping of eyelids, slurring of speech, increase at the day or at the end of day since 2 months, and the CT chest was taken for her, which showed anterior mediastinal mass, which was a possibility of thymoma. Patient's acetylcholine receptor antibody levels were more than 8, and she received 1 cycle of plasmapheresis, and she was taken for thymoma excision. So so what is this plasmapheresis? We'll see that. So therapeutic apheresis encompasses the removal of plasma or blood cells, that is cytopheresis, that is erythrocytes, leukocytes, and platelet from patient's blood. If plasma is removed not for donation but for therapeutic purpose and is replaced by donor plasma, colloid or crystalloid or mixture, then a mixture of it, uh, uh, then it is defined as therapeutic plasma exchange. To remove pathogenic plasma or to administer deficient substances present in the plasma of healthy donor, for example, disintegrane metalloproteinase with thromboplastin type 1 motif and the membrane 13 Adams 13 through potential immunomodulatory effect may be invoked. Many patients who require therapeutic plasmapheresis are critically ill, needing admission to the intensive care unit. Therapeutic plasmapheresis is the invasive procedure with often emergent indication, demanding its execution as soon as possible. Thus, a rapid response by experienced staff with specific equipment, close monitoring, and multidisciplinary management are essential. Now we'll see the indications of plasmapheresis. In ICU, indications for plasmapheresis can be divided into absolute indication, that is well established, evidence-based, for which therapeutic plasmapheresis is recognized as first-line therapy. Then there are some relative indication for which therapeutic plasmapheresis is recognized as second-line treatment alone or combined with other intervention, and rescue therapy where therapeutic plasmapheresis is used with the limited evidence of benefit. Now we will see what are these absolute indications. So absolute indications are acute inflammatory demyelinating polyradiculoneuropathy, that is disorders like GBS, then antiglomerular basement membrane disease, that is Goodpasture syndrome, then hyperviscosity syndrome, that is hypergammaglobulinemia, especially Waldenstrom macroglobulinemia, then catastrophic antiphospholipid syndrome, and then myasthenia gravis. N-methyl D-aspartate receptor antibody encephalitis, thrombotic thrombocytopenic purpura, and acute liver failure. Then relative indications are thyroid storm, ANCA-associated vasculitis with diffuse alveolar hemorrhage, acute disseminated encephalitis, thrombotic microangiopathy, complement-mediated syndrome, that is also known as a typical hemolytic syndrome, then autoimmune hemolytic anemia, then chronic acquired demyelinating polyneuropathies, that is IgA and IgG associated polyneuropathy, then Lambert-Eaton myasthenia gravis, and steroid responsive encephalopathy associated with autoimmune thyroiditis and Hashimoto encephalopathy. Then rescue indications, heparin-induced thrombocytopenia with progressive thrombosis, cryoglobulinemia, vasculitis, pancreatitis with severe hyperglycemia. Paraneoplastic neurological syndrome, specific type of poisoning, systemic lupus erythematosus with severe vasculitic complications, including lupus cerebritis and pneumonitis. Now we'll see the kinetic model and how it is playing role in therapeutic plasmapheresis. So kinetic models are for the prediction of the substance removal. The half-life and the volume of distribution of substance to be removed must be considered when planning the intensity and frequency of therapeutic plasmapheresis sessions. The plasma volume to be replaced is determined by calculating total blood volume and the total plasma volume of the patient. For substance that is neither rapidly synthesized nor redistributed and limited to intravascular space, the first session of plasma exchange will remove 65 to 70% of target substance. With additional plasma volume exchange, the absolute amount removed becomes progressively smaller due to exponential nature of the removal. And the second session will remove additional 23%, and the third session only an additional 9% of the target substance. The net reduction will be affected by redistribution from extravascular to intravascular compartment, the production rate, and by the volume of distribution. For example, one standard therapeutic plasma exchange session replacing 1.2 times of total plasma volume will remove 10 gram of IgG and 0.3 gram of IgM due to amount of IgG present in the intravascular space. Its ability to redistribute from the extravascular compartment, which does not occur in an appreciable amount with IgM. It also depends upon the IgG at baseline. The 2019 SFA recommendation suggests that exchanging 1 to 1.5 times the individually calculated therapeutic plasma volume. However, several clinical studies have shown frequent failure to reach this therapeutic plasma exchange target. A study in the German study in the German reports exchanging only 0.4 to 1 times the estimated therapeutic plasma volume. In recent study from India, the overall exchange volume during therapeutic plasma exchange for various indication was only 2.1 liter with overall response rate of 84%. And the optimal exchange volume is not known and may depend upon the disease. Small volume plasma exchange will remove less substance from the plasma but may be affordable and still effective. For example, in Bangladesh, where most patients with GBS cannot afford standard treatment with intravascular immunoglobulin and standard therapeutic plasma exchange course, a clinical study was conducted, included 20 adult patients with GBS, demonstrated the feasibility and safety of small volume plasma exchange as potential alternative to low-cost treatment. A detrimental effect of high-dose therapeutic plasma exchange have not been described, but it should be remembered that therapeutic plasma exchange also removes drugs that are aimed at treating underlying disease such as rituximab and capilacizumab or essential drugs such as antibiotic and anticoagulant. Also, if the aim is to remove larger substance, the efficacy of therapeutic plasma exchange will decrease as the total exchange volume increases, as the removed large amount of pathogenic substance may need hours to days to diffuse from extravascular to intravascular. In this case, it may be efficacious to repeat therapeutic plasma exchange session rather than continuing high volume therapeutic plasma exchange beyond 1 to 1.5 times of plasma volume. Knowledge about characteristic and kinetics of the substance to be removed is essential to guide therapeutic plasma exchange prescription. So the most rational approach to receive or to achieve most efficient substance removal is to consider nature of the toxin to be removed, the base combination of exchange volume, treatment frequency, and timing. So what are the therapeutic goals of therapeutic plasma exchange? So therapeutic goals of plasmapheresis depends upon the pathophysiology of the disease. For example, in Waldenstrom microglobulinemia, the goal is to decrease IgM level to reduce the plasma viscosity and to eliminate symptoms of hypoperfusion. In TTP, uh, the aim is to raise the platelet count above 150,000 and reversing hemolysis by removing anti-ADAM TS13 inhibitory antibodies, removing ultra-large 1 Wildman factor multimer, and replacing the ADAMS 13 enzyme. In myasthenia gravis, the aim is to achieve rapid clinical stabilization by removing acetylcholine receptor antibodies, especially in case of myasthenia crisis. In GBS, the goal is to improve muscle strength and to reduce the need for mechanical ventilation and hasten recovery. Now, what is the diagnostic workup that is needed for therapeutic plasma exchange, indications and monitoring? So, plasmapheresis is used in various medical conditions, and the diagnostic workup serve to identify the underlying disease and to determine its characteristics. During plasmapheresis, close monitoring is essential to prevent adverse event and to ensure efficacy and safety. The criteria for discontinuing plasma exchange should be determined prior. Many routine biomarkers, that is C-reactive protein, creatinine, bilirubin, will be reduced after plasmapheresis session, potentially for many hours, and therefore must be interpreted with caution. So changes in the amount of substance removed by plasmapheresis may not be necessarily represent improvement in the disease process, and the additional evidence of clinical response, such as symptom resolution, that should be sought. Similarly, a decrease in CRP level after plasmapheresis does not necessarily mean that inflammation or infection are under control. Now, the technical aspects are machine or device. During plasmapheresis, plasma can be separated from the corpuscular component of the body by centrifugation, by the membrane filtration, or by both. Centrifugation is based on the differences in the density of various blood components. Then mature RBCs have the greatest relative density, followed by young erythrocytes, granulocyte, mononuclear cell, platelet, and finally plasma. So filtration take advantage of differences in particle size to separate plasma from the cell. Currently licensed plasmapheresis devices can operate with the continuous and the intermittent flow. Both centrifugal and membrane-based devices are available. In apheresis unit based in the transfusion medicine or hematology department, plasmapheresis is usually performed with centrifugal system that often use citrate for anticoagulation. And in most nephrology department and ICU, the preferred device is membrane-based, including multi multifunctional renal replacement therapy machines. So in both, that is centrifugal and membrane-based plasmapheresis, cell-rich blood that remain after plasma is removed. Blood that remains after plasma removal is mixed with the replacement fluid. That can be anything like albumin, plasma, crystalloid, and returned to the patient to prevent hypovolemia. To reduce the cost and donor exposure, up to 30% of replacement fluid may be suitable crystal. In low resource healthcare system, plasma crystalloid and non-plasma colloid beyond 30% of replaced volume may be used for replacement due to expense of albumin substrate and the availability and safety profile of plasma products. So plasma removal efficiency is the metric used to compare uh, this therapeutic plasma exchange devices. It described as fraction of plasma that passes through the device and is removed per procedure. So plasma removal efficiency estimate may vary according to the mathematical formula used. With centrifugal plasmapheresis devices, the plasma removal efficiency is faster and higher than the membrane-based plasmapheresis devices. Rate of removal are comparable with the centrifugal plasmapheresis and membrane plasmapheresis for IgG, but not for fibrinogen. Now, vascular access. The choice for vascular access for plasmapheresis depends primarily on the method used. Centrifugal requires a low blood flow rate, that is 50 to 120 ml per minute, than the membrane-based plasmapheresis, that is 150 to 200 ml per minute. A lower blood flow rate enables the use of the narrower catheter, that is peripheral devices, and standard triple lumen central venous catheter, that is 7 French. So with peripheral vein, the single needle access is feasible when using centrifugal therapeutic plasma exchange, but might increase the treatment time. Peripherally inserted central catheter are not suitable because narrow catheter gauge will collapse with the negative pressure exerted during therapeutic plasma exchange. The membrane-based plasma exchange device often require high blood flow. Therefore, a wide catheter such as temporary hemodialysis catheter and the large diameter dual lumen catheters are used. The optimum characteristic of catheter for therapeutic plasma exchange include rigid wall, large diameter, and shorter length to reduce resistance and decrease instrumental alarm. The machine used for centrifugal plasmapheresis, centrifugal plasmapheresis can concentrate RBC to hematocrit of 80% or higher, which allows for more plasma per volume to be processed compared to the membrane-based plasmapheresis devices. A higher blood flow rate is needed with the membrane-based plasmapheresis device, as they usually extract only about 30 to 35% of processed plasma to prevent RBC damage from high hematocrit. Thus, with membrane-based plasmapheresis devices, 3 to 4 times more plasma volume must be processed to remove similar plasma volume as with centrifugal plasmapheresis device. Now, regarding anticoagulation, anticoagulation for therapeutic plasmapheresis aims to achieve a delicate balance between preventing circuit failure with loss of expensive blood component and preventing bleeding. Systemic heparin and regional citrate are the most common anticoagulant, while epoprostenol can be used when citrate is available and the heparin is contraindicated. In past, citrate was generally used for centrifugal plasmapheresis and heparin for membrane-based plasmapheresis, but citrate is now can also be used for membranous plasmapheresis. Both heparin and citrate anticoagulation have advantage and drawback. The risk during therapeutic plasma exchange is lower with citrate than with heparin. However, when citrate is used with the membrane plasma pheresis device, the side effects are more frequent, mainly because more citrate is required as a result of a high blood flow, plus removal of less plasma leads to more citrate entering to the patient's systemic circulation. Symptomatic hypocalcemia is also common with citrate and can be preventable by prophylactic calcium administration. Commercially available membrane-based plasmapheresis devices with integrated citrate administration adjusted for blood flow and calcium supplementation according to the effluent rate reduces the risk. When using heparin for anticoagulation, estimation of required dosage should be the factor in extracorporeal losses of drug and its cofactor antithrombin. Moreover, antithrombin loss may hamper anticoagulation with heparin as well as interpretation of chromogenic anti-10 10A assays that add exogenous antithrombin. Now, regarding fluid replacement, albumin or plasma can be used as replacement fluid alone or in combination with or without addition of crystalloids such as saline. Albumin is used most often as it is associated with low frequency of allergic and immune reaction. For example, transfusion-related acute lung injury compared to plasma and not associated with the risk of transfusion-transmitted disease. So this following table summarizes the pros and cons of each alternative. When albumin is used as replacement solution, metabolic acidosis may be seen after therapeutic plasma session because albumin has acidic profile, and albumin substitution may also affect the concentration of fibrinogen and other coagulant factor, resulting in profound derangement of thromboelastography parameter. Plasma is indicated when aiming to replace plasma component, that is Adams 13 in TTP. So, uh, despite the absence of hard evidence, many centers use plasma to prevent depletion of coagulation factor. For example, if bleeding diathesis is present or invasive procedure is planned. Established guidelines for hemostasis monitoring and management during plasmapheresis are lacking, but extracorporeal losses of both pro and anticoagulant factors need to be considered. A recent survey by ASFA subcommittee found wide practice variation in type of replacement fluid, but potential bleeding risk most often determines the choice. Because of the large volume and number of donor exposure and often prolonged duration of therapy, the risk of allergic reaction is higher with plasma than with albumin, and some center administered antihistamine glucocorticoid when using plasma. When plasma is used as a replacement solution, metabolic alkalosis may occur because of the metabolism of citrate used as anticoagulant and citrate present in the stored plasma. For every citrate molecule metabolized, there is consumption of hydrogen ion and production of 3 sodium bicarbonate molecules, thus increasing serum pH levels. Crystolite can be added for cost containment and in patients with hyperviscosity syndrome. However, replacing plasma with the crystolite carries the risk of hypotension if proportion of replacement with crystolite exceeds 30%. In this setting, significant fluid shift can occur as water follows its concentration gradient from intravascular space into extravascular space. When crystolite is used as a portion of replacement, it should be administered at the beginning of exchange and not at the end to avoid significant fluid shift and hypotension. Hydroxyethyl starch is no longer recommended in critically ill patients due to its harmful effect on both renal function and coagulation. However, it is still occasionally used as replacement fluid, especially in low-resource healthcare system. It may also be used in patients who refuse blood products. Now, regarding clinical response, the expected benefit and potential deleterious effect of plasmapheresis are depend on the timing of procedure with respect to onset of the illness and the volume of fluid exchange, the type of replacement solution, and the frequency and interval of plasma removal. The individual criteria for clinical response are highly disease specific, ranging from the changes in individual and multiple hematological parameters, antibody concentrations, and biochemistry to improvement of clinical signs and symptoms. Impact of plasmapheresis can be rapid and or slow or may last for weeks to months depending on the underlying disease. However, long-term effect, including psychological well-being and the risk of chronic organ dysfunction beyond acute illness, are rarely reported. Now, complication. Therapeutic plasma exchange is a relatively safe procedure and usually well tolerated. Complications include catheter-related and the procedure-related. The incidence of adverse effect have declined over time and now range from 5 to 36%, depending upon the vascular access used, type of replacement fluid, and anticoagulation. Catheter-related infections, pneumothorax, local bleeding have been reported in 0.4 to 1.6% of patients. In critically ill patient, if bleeding disorders were rare, that is less than 10%, but catheter dysfunction was the most common complication. Complication rates were similar for membrane-based and centrifugal plasmapheresis. Potential life-threatening complication dominated by anaphylactic reaction and severe hypotension have been reported in 1% to 2% of therapeutic plasma exchange session in critically ill patients. They should be minimized by judicious choice of vascular access in close collaboration with apheresis specialists. Citrate anticoagulation and plasma replacement are the risk factor for hypocalcemia and paresthesia. Plasma replacement is associated with higher risk of anaphylactic reaction. On the other hand, replacement with albumin does not correct the depletion and balancing coagulation factor immunoglobulin, resulting in potential risk of bleeding and infection respectively. Now the next is drug removal by plasmapheresis. Data on drug removal by plasmapheresis are scarce and based on the case report or case series only. For most drugs, either no information is available or it is not important. For highly protein-bound drug with the low volume distribution and for chimeric antibody, there is very effective removal. Factors associated with clinically meaningful drug removal include drug characteristic, that is volume of distribution, protein binding affinity, rate of endogenous clearance, distribution half-life, dose-related pharmacodynamics. And plasma therapeutic plasma exchange characteristic like volume of plasma removal, interval between session, time between first and last session, and timing of drug removal. Important inter and intra-individual difference in pharmacokinetics and multi-compartment mental kinetic patterns seen during plasmapheresis can make prediction very difficult. So antibiotic removal during plasmapheresis was reviewed recently. Whether antibiotic should be administered before and after therapeutic plasmapheresis depends also on its pharmacodynamic characteristics. Aminoglycoside can be best administered before procedure to benefit from both high peak with the bactericidal effect and reduced toxicity related to low trough level through extracorporeal removal. Now, the beta-lactam plasma levels, on the other hand, should be maintained above the minimum inhibitory concentration, which often require supplementary dose post-procedure. Monoclonal antibodies like rituximab have small volume distribution and long distribution half-life, therefore significantly removed by plasmapheresis. During plasmapheresis, total clearance of drug decreases over time as plasma level decreases. Although level of monoclonal antibodies correlate with clinical benefit, they may not correlate with pharmacodynamic markers. Significant removal of enoxaparin, tacrolimus, and mycophenolic acid during plasmapheresis have been reported. Most studies involve administering medication after therapeutic plasma exchange and scheduling the next plasmapheresis session 24 to 36 hours later. In general, therapeutic drug monitoring should be applied whenever possible in critically ill patients undergoing serial plasmapheresis session, especially if drug has narrow therapeutic index. Timing of sampling should account for post-procedure redistribution with the rebound of plasma concentration. Now, this is the pictorial representation of plasmapheresis process. That is the mechanism of therapeutic plasmapheresis, removal of pathogenic substance and delivery of deficient plasma component. Now, which diagnostic workup that we should follow? So we should be doing the electrolytes, liver, renal function, complete blood count, coagulation profile, any disease specific test, then infection status and the blood type. Then regarding the prescription of the therapeutic plasma exchange, we should take care of vascular access, total plasma volume that need to be replaced, number of session, interval between session, anticoagulation, type of replacement fluid, and drug dosing. And what are the things that we should be monitoring? These total biochemistry, complete blood count, coagulation profile, and disease specific test. Thank you.